Muy buenas tardes, sean todos bienvenidos a un nuevo webinar del Instituto Nacional de Salud. Este día retomamos nuestro programa del módulo de cardiología perinatal con dos conferencias magistrales internacionales, la que se desarrolló esta mañana con el doctor Fabio Sirchia de Italia y la que presenciarán en breve. Nuestro principal objetivo es llevar información de calidad a los profesionales sanitarios de todo el país para apoyar la actualización de conocimientos y generar espacios valiosos de intercambio con especialistas, que con gran disposición nos comparten su experiencia, que nos permiten aportar para las mejoras de la calidad de atención de salud que recibe la población. Este día tenemos una experta internacional, la doctora Angela D'Amore. Es consultora neonatóloga en Cambridge University Hospital. Es especialista en neurodesarrollo neonatal y neurología neonatal. Ha llevado a cabo investigaciones significativas en estas áreas y ha contribuido con obras que han recibido un número considerable de citas académicas. También es una maestra experimentada en cursos regionales de pediatría y actualmente es la jefa de la clínica de neonatología del Hospital Rossie, Addenbrookes, del Reino Unido. Sus intereses de investigación incluyen los resultados del neurodesarrollo de bebés prematuros, bebés con restricción del crecimiento intrauterino y bebés tratados con hipotermia terapéutica. Dirige un equipo multiprofesional que brinda un servicio de seguimiento del neurodesarrollo que incluye evaluaciones de Bailey a los 2 años de edad. Nuestra invitada hablará de la importancia del seguimiento a largo plazo y cuidado multidisciplinario de los bebés con enfermedades cardiovasculares congénitas. Hablamos de estos temas porque creemos que son fundamentales para el control de complicaciones tempranas y asegurar un desarrollo saludable, mejorando así la calidad de vida del paciente, aspecto que ya nos ampliará la doctora D'Amore. Estimados participantes, gracias por estar presentes. Pueden dejar sus preguntas en el chat y la doctora responderá al finalizar su conferencia. Doctora Angela, bienvenida. Agradecemos mucho su disposición. Puede iniciar su conferencia.
Gracias. Muchas gracias. Did I share my screen? Where's it gone? Can you see my screen? Okay. All right. So thank you very much. I'm going to talk a little bit about long-term follow-up and multidisciplinary care of babies with congenital cardiovascular diseases. Okay. As the doctor said, I'm a neonatologist, but I work with many other professionals and when we're looking after babies with congenital cardiac disease. So I'm going to talk a little bit about cardiac disease, how we work together to share the care of the baby and the mother, what we do on the neonatal unit, and a little bit about the longer term neurodevelopment outcomes for babies with congenital heart disease. So congenital heart disease is the most common congenital anomaly in babies with an incidence of about 8 per 1,000 births. Okay. And it's a leading cause of death in infancy. About over 300 children will die in infancy in the UK. I can't. Vanessa, I seem to have lost you. Don't know. Oh, okay, sorry. Okay. So this is the incidence of children born with congenital heart disease, and you can see it varies from country to country. So the highest incidence is in Africa, interestingly. Nobody really knows why that is. Shall I carry on, Vanessa? I can't. I don't. I'm not sure if anybody can hear what I'm saying. Oh, okay. All right. So I can't hear what Vanessa's saying. Anyway, so these are the risk factors for congenital heart disease. We don't really know why, and only about 20% will have a known genetic condition. But we do know that if there's a family history, then there's an increased risk to the babies. And we also know that maternal conditions such as diabetes and obesity do increase the risk of congenital heart disease in their babies. And also some maternal medications, if the mum is taking ACE inhibitors or acne treatment, then that does have an increased risk in congenital heart disease in the babies. So the care of babies starts with the mother and prenatal care, then the neonatal care, and then in the long-term pediatric care. So it spans the whole, it's a very long journey. So it starts with, in Britain, it will start with the routine, it may be picked up on an antenatal ultrasound scan, and then they will, if there's something seen, they'll have some fetal medicine input. And then if it's quite significant, we might have specialist pediatric cardiologists who come and do a fetal echocardiogram. This then allows us to have prenatal counselling with the mother and the family, and we'll involve a neonatologist there to talk about what will happen to the baby after the delivery. We will then plan the delivery and where the best place to deliver the baby is, and that'll be along with the obstetrician. And then the neonatal team will look after the baby after it's born when it's admitted to the neonatal unit. They will then, if it's a complex condition, we'll talk to the cardiologist who will advise us. And then it may be that the babies need to be transferred out to a very specialist cardiac centre, which for us in Cambridge will be in London. And then later they may need cardiac surgery, so they will then need a cardiothoracic surgeon. So that you can see there are many, many professionals involved in the care of the baby. So this shows that that they need lots of specialists. They'll need cardiologists, they'll need a neonatologist. Quite often we will ask a geneticist to be involved as well. And later they will need pediatric intensivists, pediatric cardiologists, and pediatric cardiothoracic surgeons. So why should we, what is the advantage of picking up a heart defect before a baby's born? Well, the idea is that if you know that the baby's going to have a complex heart condition after birth, then it will allow you to investigate or have a look and see if there are any other anomalies before the baby's born. And there is some increasing evidence that if you know that the baby's going to need specialist cardiac input after birth, that it does seem to improve the outcomes for the babies. And it also, if you know that there's possibly a cardiac condition, then you are prepared for the baby after delivery, because as we all know, the last thing you want is for a baby to collapse on a neonatal unit or after birth, because that leads to, if the baby has a cardiogenic shock or circulatory collapse, then that really is not the best thing. And if you know that the baby is going to have a cardiac complication, then you can be prepared and treat the baby before it collapses. Oh, sorry, I've gone the wrong way there. Sorry. So this is really a challenge, because this is just a very brief slide to show you that basically the heart is fully formed by day 50, which is quite early on. And it may be that women aren't even aware that they're pregnant by the time that the heart is fully formed. So it's quite a challenge. So if you know that the baby's got a possible cardiac problem, then when would be the best time to deliver the baby? You would think maybe you would plan to deliver the baby by cesarean section, but there's not really a lot of evidence that that's necessary unless it's a very complex cardiac lesion. And it's quite all right to let the baby have a normal delivery. What we do know is that that really under 39 weeks is best if you don't deliver the baby early, because if they deliver them early, then they do have increased mortality, morbidity, and worse outcomes. And this is probably because obviously the more preterm you deliver the baby, then that increases the likelihood of having increased brain injury. So the most would recommend that if you know it's a cardiac condition, just plan to deliver the baby maybe around 39 weeks. We also know that babies with congenital heart disease are much more likely to go into premature labour spontaneously, which is not helpful. We also know, and this is in part because we know that the placenta, the fetal placenta, doesn't perfuse very well. It also has chronic inflammation because of the abnormal blood flow, and often doesn't function very well. So the babies not only have a heart defect, but they will be born with low birth weight, and they will also be born prematurely, which also increases the risks of further complications. So what are we going to do as neonatologists? Well, as neonatologists, we're there to stabilise the baby at delivery. Maybe the baby will need resuscitation. The baby may need some respiratory care. They may need some respiratory support with CPAP, or it's usually that they're not born in particularly needing a lot of respiratory care unless they're born very prematurely. If we know that there's a possibility that the baby might have a duct-dependent lesion, then you might consider putting in a central line fairly early on. And I'll talk a little bit about that, about when you need to give prostaglandin. It's really important from a neonatal point of view that they have the best nutrition and feeding that they can, because that's important. We also need to think about how we're going to offer neuroprotection, because these babies are at significant risk of having brain injuries, and I'll talk a little bit about that later. In the UK and the US, obviously, we are able to transfer babies to specialist cardiac centres. So we have to stabilise them so that they are ready to be able to be transferred. And not all babies, sadly, are able, even in the UK or the US, there are some babies who are born with such complex cardiac disease that there is no surgery that may be offered, and they may then stay on the neonatal unit and not be transferred to a cardiac centre. So, as I said, we would give respiratory support. We would, if we can, we would do a echocardiogram if we have the expertise. And a lot of neonatal units in Britain will have a neonatologist who does basic echocardiograms. We'd obviously do a chest X-ray and an ECG possibly. And then the really important thing for us on the neonatal unit is this a cardiac lesion that needs prostin, or does it not? Because if it does, then we want to start that as soon as possible. What is also important is that particularly if the baby's born early, we absolutely must not use too much oxygen, and we don't need to use inotropes because this will lead to a further compromise of the gut and renal perfusion. And this is just a very brief thing, but there are some complex cardiac lesions that absolutely need immediate perinatal intervention, either from a neonatal point of view, and we would do all of this, and they need to be transferred really if the baby's going to survive, to a cardiac centre quite quickly. The absolute classic one is the transposition of the great arteries with no atrial connection. And that baby would need a balloon septostomy really urgently. And then the other challenge for us as neonatologists, particularly babies that we don't know, because even with the best ultrasound skills in the world, we still only pick up around 50 to 60% of babies prenatally. The challenge for us as neonatologists is if a baby collapses or is in circulatory shock, how do we know that that is a cardiac lesion or is it sepsis? Sometimes it can be both at the same time. And it's really difficult for us as neonatologists sometimes to differentiate between a baby with an obstructed circulation, such as a critical aortic stenosis, or a coarct with neonatal sepsis. And the incidence of them is similar. The main thing that is of help is that usually your PDA doesn't close immediately after birth. So if a baby presents sort of later, 2 to 3 days later, then that is much more likely to be a duct-dependent lesion than sepsis. I'm not going to go through these in great detail, but these are just some of the neonatal management that we would do for babies on the neonatal unit if we suspect there's a cardiac lesion. And we do all of these. We have great support from the cardiologist teams in London. We talk to them on the phone. We get advice from them. We also are fortunate to be able to transfer images both of our chest X-rays and of our echoes to the team. It's usually Great Ormond Street. And we can do that because all our X-rays and echoes are digital, and they can then see our images, look at the echoes, and then they will advise us as what is a best course of action to stabilise the baby, and then if we need to transfer the baby using the transport team down into the cardiac centre. There are two presentations that don't need immediate transfer, and these where you have babies who have a left to right shunt, such as a big AVSD or a VSD, so these babies don't need immediate transfer, and we can look after them on the neonatal unit. We can blue restrict them, diuretics, and we will accept lower saturations. We won't try and give them lots of oxygen to keep up their saturations into the high 90s. The other babies that can stay on the neonatal unit for quite a while are the truncus arteriosus or some tricuspid atresias, and these babies will be cyanotic, but they they don't need to be rushed down to a cardiac centre. They do need follow-up, but they don't need, it's not an emergency situation. And the important thing with these babies, if we do know that they have this particular lesion, and we don't chase their oxygen saturations, we let them run along with high 70s. The critical conditions are things where you've got an obstructed systemic circulation, such as an interrupted aortic arch or hyperplastic left heart syndrome, and those babies need a prostaglandin infusion and then a transfer to a cardiac centre, as is any child with severe pulmonary atresia, or the absolute one is the transposition with an intact ventricular septum that absolutely needs to either have a balloon septostomy or be transferred as soon as possible. So prostaglandin is a great drug, and it works really well in a duct-dependent lesion for our babies, but it is a very potent vasodilator, so can have quite significant side effects when we use it, and the main ones being apnea and hypertension. So sometimes you do need to consider giving the babies respiratory support, especially if you have relatively high doses. The really crucial thing about if we do need to give prostaglandin is that it is incredibly rapidly metabolized, and therefore it has to be a continuous infusion. And we usually, that's why, if at all possible, you would give it through a central line, and you'd have a backup of an additional line, because it is that sensitive that if it stops, then the duct can close quite quickly. This is, so I don't know why I put this in here, but the other thing that we do in Britain, which is quite helpful postnatally, is we now do pulse oximetry screening in the first 24 hours of a baby's life, where we do pre and post ductal saturations, just using the ordinary saturation monitor. With the right hand is your pre-ductal, and anywhere either foot is your post-ductal saturation. And you can have a little bit of a difference, but if it's any more than 3%, then we would further investigate the baby. And our midwives do this on our, the nurses do it on the postnatal wards. And it has been thought to, since it's been introduced nationally, that it has saved a few babies. We've picked up some congenital heart disease that we wouldn't have picked up otherwise. So the other area that sometimes manifests itself on our neonatal unit is heart tachyarrhythmias and bradyarrhythmias, although these are not that common for us. And also it's worth remembering that our tachyarrhythmias also can occur in the normally structurally normal heart. So you're not going to pick that up on any scans, but the babies can have SVTs that you won't pick up on any imaging. And also some babies have SVTs prenatally, and that's why they are born with high drops. So what about the outcomes for these babies? Well, about 50%, it's now clear that about 50% of children who have complex congenital heart disease will have significant neurodevelopmental outcomes. About a quarter of them, they have microcephaly. And what is becoming clear is that there are many, many similarities in the changes in the brain and the neurodevelopmental outcomes for babies with who are born prematurely and babies who have congenital heart disease. And it's probably some similar underlying mechanisms, because they both are white matter injuries. And there's emerging evidence that a lot of these changes happen for babies with congenital heart disease in utero because of the abnormal blood flows. So that's why if it is possible to pick it up prenatally, then the idea is that maybe there aren't any at the moment, but maybe in the future there may be some interventions that we can do to prevent the brain injuries. And we certainly need to think about what we can do after birth that will really help the not cause any further brain injury. And this is just a very brief picture to show that basically there are so many things. It's very multifactorial, but there's a lot of injury that occurs in utero, which leads to delayed brain development. And then obviously if you have a heart disease, then there's all many other factors. If you have heart surgery, then more than one surgery, that also leads to further white matter injury. So we need to try and think about what we do pre-birth, before, at birth, and then after birth, if we want to improve the outcomes for these children. And this is just to show that even in the fetus, they've been doing fetal MRIs in babies with congenital heart disease. And what is becoming apparent is that even in utero, there are already changes that can be seen on a fetal MRI that are not isolated, but they're secondary to the congenital heart disease. And it's usually because the brain doesn't develop properly. So it's got a decreased volume, and it's also got an abnormal micro structure. So what we need to try and do as neonatologists and pediatricians is we need to try and optimize the growth and the neurodevelopment and reduce the impact of all the other things that happen to babies after they're born. And because these babies, if they have surgery, we all know that surgery is not great for an immature brain, and particularly cardiac surgery, where you've got bypass, or you've got several episodes of hypoxemia. They're at risk of thromboembolic events, and there's a prolonged anaesthetic. So all of these are not great in an already compromised baby with an already compromised brain. And so, as well as providing, and we're very good at this as neonatologists, we know that we've got to provide good medical care, but we also know there's a lot of other developmental care that we need to do for our babies. And we as neonatologists, we have learned that, and we are very good at it, whereas the pediatric intensive care units are maybe not quite so advanced as we are, but there is a lot of recognition now that between the cardiac intensivists and pediatric intensivists, that they also, particularly for the small babies and young children, that they actually need to do a lot more developmental care as well as the medical care. So these are the sort of things that we can do that really are very easy to do, and they will help babies developing brains. It's things like making sure we minimize the amount of noise, we use good positioning, keep our babies have some cycle lighting so that they're not exposed to bright lights 24 hours a day, and where we can use non-pharmacological comfort measures such as sucrose or being kangaroo care, which is really good. The other really good thing that we can do as neonatologists or pediatricians is really try and help improve, make sure that the babies have adequate nutrition, because if they don't grow, that's not going to be any good, and that's going to make their brain matter injuries even worse. So it's not just about growing, but we know that nutrition also protects and helps protect against white matter injury, and that's thought to be that if you have oral feeds, it helps your microbiome in your gut brain axis, and it's better for the baby, even if it's in small amounts already, rather than restricting the amount of oral milk. And then there's a big debate about if they do need cardiac surgery, should you do it early or can you wait? And nobody really knows but what we do know is we've had babies who are born very prematurely with significant heart disease, and if they're less than 2 kilos, it's really difficult for the surgeons, apart from closing the ducts, which they will do. But so often they will stay on the neonatal unit, and we will grow them, support them. And we've had babies who have been on Prostin for sometimes several weeks, so that they can get a little bit bigger, a little bit stronger before they will do the cardiac surgery. There are disadvantages if you delay the surgery, because maybe that's just making the complications worse with the abnormal blood flows. But so it's all a balance of risk. And this is where multidisciplinary working becomes important, because the neonatologist has to work with the cardiologists and the cardiac surgeons to decide when is the best time. It's all a balance of risks. And that's just to show you that and so this is just showing you that all the many things that happen to babies with congenital heart disease, and how every step of the way there are risk factors for their neurodevelopment, starting right at the beginning with genetics, then your cerebral blood flow in utero, then all the operations, all the perioperative things that happen, the anesthetics, the hypertensions, and then prolonged hospital stays. So we know that a cardiopulmonary bypass is really not great. It's important, but it makes you hypoxic. It gives you a hyperinflammatory response. We know that it causes increased incidence of thromboemboli. We know that if you leave a baby with chronic cyanosis without surgery, like a tetralogy of Fallot, they have chronic hypoxemia. So that's not great either. There's a lot of children who have ECMO or cardiopulmonary bypass. They often have seizures post-operatively. We know that children with cardiac disease don't grow, and even if they've got optimal nutrition, sometimes they have growth failure. Some children, unfortunately, have cardiac arrests because they have arrhythmias. So there's a lot of risk factors. But we do know that, with better care and better treatments and surgery, that nearly over 90% of children born will now survive into quite late childhood or even adulthood. But what we also is becoming clear is that that nearly all the organ systems are affected in adults who have had either untreated cardiac congenital disease, or they've had treated congenital heart disease. So we need to think about that. And these are just some of the complications. There's a whole load of neurodevelopmental complications, and they're very similar to the changes that you see in the very premature babies. They have cognition, they have learning problems, they have speech problems, they have higher rates of autism and motor skills impairments. Interestingly, there's also evidence that they, as they grow into adulthood, they have a higher rate of dementia. But they also have lots of medical complications, things such as they have increased risks of respiratory infections, they might have endocarditis, they can have strokes, they definitely do have hypertension, they can have heart failure, they can have arrhythmias, so that they have lots and lots of medical complications. And this is just showing that most babies, it's not an isolated defect, even though you think, oh, it's just that the heart disease, and if we correct that, then everything's going to be all right. It really just does affect all sorts of organs, and babies are affected. Particularly, they seem to have also a slightly, they do have a decreased immune response, so they're much more vulnerable to infections. Their lungs just don't work as well, so they often have quite significant lung disease, and particularly if they've got a left to right shunt with increased pulmonary blood flow, they're at great risk of getting pulmonary hypertension. So that's that. And this is just, and there is definitely reduced survival in adults now. We know that there's a lot of evidence that the commonest cause is renal failure, probably secondary to the impaired renal flow, lung disease because of the pulmonary blood flow, and also atherosclerotic cardiovascular disease in adulthood, which is obviously much more common when in following cardiac surgery. So what we have learned recently is that a lot of the problems arise in utero or before you've diagnosed the cardiac condition. It's really important that we work together as neonatologists and obstetricians and pediatricians to look after the immediate care of babies born. And as neonatologists, we should be able to manage and stabilize any baby that's born with. We don't need to know the exact complexity of the heart disease, but we need to know how best to stabilize and support the babies after birth so that we can get them to cardiac centres if needed. And we know that, as with premature babies, all neurodevelopment is driven by the environment that the baby is in, and it's really important to have good growth. And it's become much more recognised, as it has in neonatology, that neurodevelopmental care is a really critical component of treatment. It's not, and that even by doing neuroprotective measures, that really can make a difference to the outcomes. We know that the brain injury and the abnormal brain development that occurs in these babies begins prenatally and carries on. And only by improving detection of that and identifying risk factors and possibly thinking about fetal intervention strategies or things that we can do after the baby's born will the outcomes for these babies improve. So with improved survival and greater understanding for babies with congenital heart disease, there is now much more focus on what we can do for these babies now to protect their brains before they have their cardiac surgery. And we need to have multidisciplinary working with lots and lots of teams. We need the obstetricians, the fetal medicine people, the neonatologists, the nursing teams, the pediatricians, the pediatric cardiologists, the pediatric cardiodentists, anaesthetists and cardiothoracic surgeons. So there are many, many teams that are involved in the care of these children. And I think that is all. That's the end of it. Okay, so shall I? Yeah. Very happy if anybody's got any questions or.
Muchas gracias, Ángela, por la presentación. Tengo una pregunta. ¿Qué intervenciones están haciendo o si existen intervenciones a nivel de microbiota para poder atender a los prematuros? Si está haciendo algún ensayo o alguna intervención. Pues en tu presentación hablaba sobre la importancia de la microbiota y sobre el desarrollo neurológico.
So I don't think they do this for the cardiac babies, but we do for the preterm babies. We give them probiotics, which has some help. We try to avoid giving, although we're not very good at it, but we try to avoid giving unnecessary antibiotics as well. But we do give all our preterm babies, and obviously the other one that's important for the preterm babies and the babies on the neonatal unit is breast milk.
Muchas gracias por tu respuesta. Tenemos otra pregunta. ¿Existe alguna recomendación para mujeres embarazadas para disminuir la incidencia de malformaciones cardíacas?
Yes, so good control of diabetes, no smoking, because smoking is also thought to have increased risk, and avoid some of the known drugs that cause increased risk. Although they're not common, there are some drugs that mothers should avoid taking. But the biggest one at the moment would be good control of diabetes.
Muy bien, no tenemos más preguntas.